Yeah, thank you for the kind introduction, and I'm sure you agree that the talk by Prof. Pang has been very engaging and very informative. There are many catchphrases that I caught, and one of it is life is a game, and sometimes we do feel that you are being played. So I just want to say that, I will try to actually speed up because I stand between you and the tea break. And I do hope not to actually reduce your tea break time drastically. So I think without further ado, I would like to actually go on to the talk proper. Maybe by a show of hand, may I know how many of the audience here are healthcare worker or works in a health field, even if you are from Ministry of Health and administrator only? Okay. How many of you are from the industry or academia? That means you're engineer, programmer, game developer. Okay, thank you. So welcome again. I think my talk, part of it is about providing the context, why serious game is being examined in the healthcare field, especially in rehab medicine. And number two is to do some literature review. And the third is that I will hope to highlight some lessons that we have learned, and also areas that together we as a whole can actually contribute to actually understand this more. If you have visited a healthcare institution, for example, a hospital in the last 5 to 10 years, you will agree with me that technology marches on. And things that we can only read in science five books and movies is happening in the hospital. The doctors now don't just go to see the patient with the case note and paper. They bring a computer with them. Now, nobody actually read the printed X-ray films. The medical student in Lee Kuan Yew School of Medicine, each of them is given an iPad, and e-learning is a prevalent mode of e-education. And in some surgery, the surgeon don't even stand next to you, and he's actually controlling the robot using a joystick. So it does give the impression to you that we in the health field are early adopters of technology. Sometimes it may even give the very wrong impression that we are a lot of money and we wanted to actually spend it and then try new things. That is definitely not true. The reason why you see such a rapid adoption of technology is because of the inherent needs that we need to provide health practice in efficacious, effective, and also economical ways, because that is actually the trend. The health burden of every country is exploding, not just because of an aging population, but because of many other things. So that's the first context I want to say. Technology is here to stay. Healthcare workers has to deal with technology very rapidly. But the basis of where all this investigation into technology and new medium is because of the inherent need, the call to actually develop healthcare better. Fun and engagement using games, whether is it in using a computer, video game, or using other ways, Dr. Christina asked a question, has been part of rehabilitation for very long. The picture on the right, your left, is taken more than 30 years ago, showing rehab patients playing volleyball on a wheelchair. The picture on your right side is pretty new and showing our nursing colleague engaging patients in leisure activities and also diversional therapy with some training component. We are proud to say that we have connection with some of the gaming company. This is a picture taken again, more than 20 years ago of the PlayStation, brand new, introduced into Tan Sing Rehab Center by the general manager of Sony Singapore. And you can see that the head of department, Dr. William Chan, is the first one who will lay his hand on it, together with Christopher Kwa. I'm not sure whether Chris is here or not, our therapist. Before the patient even had a chance to using it, and there we see some of our neuro rehab patients using it. Now these are pictures all taken very recently. Not just computer and video gaming, not just technology that requires very expensive equipment. Things that require very simple equipment is still very prevalently used in physical rehabilitations, and you can actually see it on there. So the second context that I would like to actually bring up to, when we actually investigate a new modality of treatment, especially in the field of rehab medicine, we have to actually understand what are the basic science and what have been the evidence behind it. Because we can easily get caught up with the technology and throw all our principles and our basic sciences knowledge out of the window. In the past, we have empirical evidence and also experience that is passed down from generation on how we should actually train our patient in physical rehabilitation. But thankfully, from the 1990s and the 2000s, we moved into evidence-based medicine, especially in the field of stroke rehabilitation, where animal studies, functional MRI, cognitive and also social behavior examination shows the following principles that we have adopted for a very long time to be true. Things like early intervention, high intensity, task specificity, meaning, how do you actually deliver and convey the meaning to the patient? And very importantly, how we can actually continue the therapy right into the community phase. All this has been proven as by scientific principles. However, listen to the context now. Looking at it in our current context, in the provision of physical rehabilitation, how many of this is being consistently delivered? Intensity. Even in a very high-tech rehab center, the most 1 to 2 hours. Not enough intensity when we compare with animal studies. Task specificity, engagement, meaningful to the patient, and continuity to the community is still definitely not being very well done in the present phase. So that's the second context. The need to deliver what we are delivering now in more efficacious, effective, and economy way. So therefore, when we examine serious gaming, the use of robotic, the use of telehealth, all this is the context. In 2006, Nintendo introduced the Wii, and it revolutionized how we connect and interface with game. I think another concept and phrase that Prof. Fang has brought up, I felt was very important. The word is interface. How do we interact with our patient? So the game and the method of rehabilitation is not just for the client. And I have to define the client is not just the patient. The client includes the healthcare deliverer, the healthcare provider itself. So the game itself is a user interface. No different from robotic, no different from virtual reality. In 2008, we start to design our pilot study, and it was being published in 2010. It's a single arm. So all these efficacious data, although it's statistically significant using Figo-Mayer motricity in stroke upper limb, doesn't mean a thing because it's not randomized control. But interestingly, in this study, it was shown that even if the patient belongs to a group, and Prof. Fang says that he treats patients that inherently would like to play game because of a pediatric population. We treat people who inherently doesn't like to play game. And in our study, we asked them, they say that that's not their hobby. Many of them, in fact, 85% of them never played a game before. Computer game, not any type of game, okay? Computer game. And they would not consider using games as part of their rehabilitation. Despite that, the level of enjoyment, the willingness to actually continue to use it, and the willingness to actually recommend it to other patients, and we are talking about we here, is very, very high. And it also confirms the other studies previously that the adverse effect is very low. And in this study, the intervention intensity is actually not very high, 3 times a week. So we begin the journey. The study itself is not important. The journey itself is important. The journey is something that you and me is going through at the present moment. We brought in the consoles. We brought in the games. We get a few people interested. All of us can do that. We allow our colleagues and ourselves to experience it. We get feedback from some of our patients. We didn't tell them that it's something that is going to help you. In fact, we tell them that it's something that we do not know. We cannot charge the patient. There's no charge code that we can give. But importantly, the other arm that we went into is to seriously set up a group that will actually investigate, to actually do literature review, to connect with other organizations, to actually design our own study. And I must say, the designing of the study itself helped us to really break down the games and ask ourselves how it compares to our principles, how it fills the gap and niche that the present modality cannot perform. And through that, we have managed to actually build a group of people that is passionate about it. And we are very glad that we can connect with Serious Game Association. Through the organization of this talk, I must say that, although we put in a lot of effort Dr. Low, for example, Ernest, for example, Prof. Fang has been very encouraging. Very encouraging. You know, I got a bit worried when we have to go for organization meeting, and then I said, oh, I'm going to meet the chairman of medical board of another institution. And then I also know that my CEO is here attending the conference. I get very pressurized. But, you know, they are the people who actually shows, you know, that age is no limit. You can be born in 1966, I'm born in 1968. We are playing games. We like it. And we see the potential. And we didn't just see it, we wanted to actually engage. We wanted to actually engage with our collaborator from the academia, from the game developer, from the authorities, and also, you know, I hope to be actually have the chance to actually start up a group, a special interest group in health gaming, so that we can actually examine more of the more important questions. So time check is 10 o'clock. I am 1/3 of my way. Can I get first permission from the organizer that I continue and the audience? Yeah, I'm not sure whether SMU allow us to bring in the tea here. Yeah, I quite enjoy the conference because, you know, Prof. Fang asked me whether he should wear a coat. He saw me wearing a coat. I'm wearing a very leisure coat. I'm not even wearing a tie. I was even thinking of actually wearing the Tan Tock Seng Rehab Center t-shirt. And that's the milieu where we can actually work together. And we want to actually, you know, try to actually entice you to actually join the group. Okay, coming to literature review. I am missing one slide. I certainly call your attention now. Okay, so if you use the word gaming together with rehabilitation, and you do a PubMed search, you will bring up only 80-something articles. And out of all these articles, some of it is about gaming addiction. So if you remove it, you will end up only having 80 studies. And out of this 80 study, if you use another search term, you use virtual reality with rehabilitation, you come up with 600 over search terms. So what does it mean now? Like Prof. Fang has actually highlighted just now, gaming for rehabilitation and gaming for health is yet a term that is undefined. It overlaps with a lot of things. In virtual reality, for those who are therapists here, you will realize that a lot of it, the user interface has got gaming component in it. And for those of you who actually play game, you may not feel that you are wearing an Oculus Rift and you are immersive, but you actually measure your pulse rate. You see how hard you're holding your console, your controller. You realize it's already immersive. So virtual reality and gaming is actually a subset of each other. Now, out of all this literature, what do we see? Well, what are the trends? Nintendo Wii is still the predominant platform where researchers is researching, and it's still carrying on, although the sale has gone down. Following that is actually customized systems that engineers, scientists build with or without the clinicians. And this actually being pushed up into a market. And one of this that is being pushed out is a rehab gaming system, RGS, that is produced in America and is actually already commercially available. They have a website in it. You can Google RGS. It's using Kinect. You need to wear a glove, and it's used to actually treat upper limb. And the studies is all in strokes. And far behind these two is Microsoft Kinect. So it's a little bit surprising to me why there is so few studies. And all these studies are mainly done by the academia. It's about how do you actually customize the Kinect camera using PC software to actually engage patients. Some of the purpose-built platform is very interesting. You've got the eBavia that is actually for balance. You have the rehab gaming system, which I mentioned, is for neurorehabilitation. You've got the BCI system, okay, the brain-computer interface, and Prof. Fang has actually demonstrated its use in child psychology. You've got robotic-based system, including Hokoma and Meet Manners. So some of you therapists may not agree that these are gaming rehabilitation, but you will definitely agree that part of how they interact with the patient, remember what I say, interfacing, is a game. So I want to actually show this article which has pictures, and this is just published not too long ago by Sri Kesavan et al. And essentially what it does is that it uses a modified computer mouse that is able to actually track 3D motion, not just two-dimensional motion. And using very simple interface, which is essentially a wooden block, and a tape measure, micropore. You tape it to everyday equipment. It's not just a cup, it is the cup that the patient used. So from very advanced things that require plenty of hardware development to very simple thing, but we have a very sophisticated software behind that actually tracks the activation time, the execution time, how accurate the person actually perform a task. And all these are physical measure and not just functional skill that someone arbitrarily score. Physical measure, timing, accuracy, degree of movement. And essentially the pictures on top, you can actually see that the person is trying to actually do a turning using a bottle cap. And the turning can be converted to turning a ball. And the bottom two is basically strength training and range of motion training. You can actually hold something with the mouse distally, and the D picture is actually holding a dumbbell, trying to actually do wrist extension. So essentially, I was quite impressed when I actually see this, and I hope that there is a chance to actually connect with the investigator. Hardware-wise, not very difficult. Software, very sophisticated. Customizable, patient choose the equipment that he's actually doing training. And the therapists have the chance to actually interact, to actually see what type of thing is being done, because the mouse essentially is driven by the software that can be expanded. What are the diagnostic group that is being studied? Neurorehabilitation is still the number one, especially stroke rehabilitation, and not surprisingly, following by pediatric groups. Musculoskeletal condition, including amputation, osteoarthritis, and pain, is also being investigated. Balance and fall, especially in geriatric population, whether is it in institution or in the community, the number of study is less than 10. It's actually not a lot. And other include burn rehabilitation, eye rehabilitation, vestibular rehabilitation, and also activity promotion, basically health promotion in the geriatric community dweller. So essentially, we see a large spread. What about the evidence? Now, my good colleague, Dr. Loh Yong-Ju, has presented this before. Now, when he did an examination about a year ago, there wasn't any randomized control trial. If you're actually looking at consoles, that means commercial off-the-shelf in stroke rehabilitation, all of them are non-randomized trials. And you can see that the largest number, I'm sorry that is a bit small, is 22. Very, 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 very small study. Okay. How about this week, when I did another examination? There are a few randomized control trials now. Okay, and only one of them is actually, two of them in fact is actually using stroke. So I just want to actually highlight some of it. Okay, in the study by Fritz et al. That was just actually published this year, the number of stroke patients is actually 30. And the range is from 3 months to 3 years post-stroke. Okay, they are comparing a pure gaming group versus a usual care group. And this is in the community. 4 times a week for 5 weeks. It's actually not easy to do, 4 times a week in the community setting. But unfortunately, there is no significant difference in functional measure of balance and mobility. They are testing for balance and ability to actually walk in both groups. But the effect size leans towards advantage in the gaming group. So what impresses me is that the ability to actually do 4 times a week for 5 weeks in the community, that is not easy. I think definitely not easy in Singapore. Salam et al. Is the other study. 40 patients was actually randomized. These are pediatric patients with developmental delay. They are using a Wii gaming versus a control group. Control group is basically nothing being done. This twice a week for 10 weeks. Okay? And they tested several measures, and one of it is actually lower limb. Single stance and grip strength in this developmental delay, basically physical functioning, was significantly improved in the Wii group. Fung et al. Randomized 50 post-total knee replacement, moving into orthopedic medicine, using Wii Fit. If you ask me among Wii, which is the platform being the investigator most, the answer is Wii Fit, not the Wii Mode. It's a 15-minute session after the traditional physical therapy versus extra physiotherapy. And not surprisingly, there is no significant difference in the knee range of motion, the 2-minute walk test, time standing task, balance confidence skill, essentially nothing is different, even patient satisfaction. So it's comparing extra V with extra physiotherapy after total knee replacement. No difference. But not inferior. That's what he's saying, not inferior. Level et al. Is from the group from Flinders University. It randomized 44 geriatric patients in a ward-based program comparing VFit versus conventional rehab, again, therapy. Although the univariate study didn't show any positivity, the multivariate study leans against gaming group using the primary outcome of time up and go test. These are deconditioned geriatric patients in the geriatric ward undergoing rehabilitation, and they stay there usually for at least 6 weeks in Australia, Southern Australia, where rehabilitation is very strong together with geriatric care. There will be other study by Da Silva et al. Using the rehab gaming system for chronic stroke. Cruz et al. Cystic fibrosis, energy expenditure using V. Who et al. In ILTC sector using V bowling compared to standard exercise therapy. All this, basically, I can summarize by this. Not significant effect size. Non-inferior. Not much side effect. Patient satisfaction usually high. We are not very sure that after the study is done, it will be continued. The same author, Lava et al., published a Cochrane review on the virtual reality for stroke rehabilitation. This is published in the Europe Journal of Physical Rehab Medicine 2012. Altogether, there are 19 randomized controlled trials between 2004 and 2010. And you can notice only 565 patients. Essentially, all of us have a task to actually contribute to the amount of literature. On the virtual reality for stroke, it is a positive systemic review. Virtual reality is proven in this study to improve upper limb function based on 7 studies, ADL based on 3 studies. There's no significant no significant difference for impairment. That means the grip strength, and also no significant improvement in terms of gait speed, which is a physical measure. And that itself is interesting. We know that in ICF, for those of us who are health, International Classification of Function, we look first at impairment, disability, handicap, and gaming for rehabilitation so far has proven a little bit of evidence in terms of improving activities level. But in terms of improving impairment level, body function level, it has actually no data at the present moment, or no convincing data. Okay? And the conclusion is that we can actually investigate commercial off-the-shelf games as one form of a VRR, and the study design using consort guideline. This is published not too long after level study by Gustavo in Stroke, which is a very high impact journal. Another systemic review on virtual reality in stroke rehabilitation. And it included 1 or 2 studies that is different from Lava study. And the evidence is a little bit stronger now, including a little bit on range of motion. I'm coming almost to the end. Thank you for bearing with me. There's a Cochrane review on home-based therapy program for upper limb function following stroke. And in this home-based program Cochrane review, although there wasn't enough evidence, the author nonetheless suggests that commercial off-the-shelf, that means gaming console, be considered as one of the areas for further investigation. So essentially, there is lack of evidence to actually prove that gaming for rehabilitation actually works. But we know the context. We know the deficiency in our health and especially rehab delivery system. We ourselves who have actually experienced some of this see the potential. So what is the way forward? I propose that we will still need to actually continue to actually experience it in our routine practice. But obviously we can't sell it. And when I say experience it, I am saying that we need to experience it in a multidisciplinary fashion. The doctors will need to talk to the therapists. The nurses will need to be in. Overseas rehab center and hospital have engineers as part of their team. We can consider ourselves unlucky because none of our hospital got engineer, but we can consider ourselves lucky because our proximity to engineers and scientists in the academia is actually very close. And now we got the developer and perhaps some of the funders around. There is definitely a need to actually contribute to well-designed research trials. And I would say that for stroke rehabilitation, something like the rigorosity of the CIM, the EXCITE trials, if possible. And we need to actually collaborate together for customized serious gaming system with virtual reality and gaming design elements that are motivating. We are talking of collaboration between psychologists, psychiatrists, and rehabilitation specialists, because the motivation part is something that is not investigated or published at all. The NMC, which is a Hewlett-Packard started organization, essentially is a technology think tank. In the Horizon report in 2013, predicted a few things that will become common day use in the next 10 years. One of it is 3D printing. Path to adoption, 4 to 5 years. We are seeing it now, but not mass market. How about game and gamification? 2 to 3 years. We are already 1 year into this report. So I submit to you that we are at the threshold whereby a new modality is being introduced. You and me can contribute to this body of knowledge and to actually define it better, to work together with our collaborator that may actually be able to actually see its birth, because one day we will be using it. I reversed my statement just now when I say that we treat a group of patients that does not play game. That is correct in 2001 and 2002. In 2030, we'll be treating a group of patients that wants to play game. And hopefully, they are not being played by the game. So my last slide, I want to acknowledge my gaming rehab SIG, Dr. Lo Yongju, Ernest Tia, Donna Shi, Christopher, they're all therapists. And kind advice from Dr. Kong Keng Yi, Yan Wei Ling, Pang Hang, Seng Kui, Jin Kun. Thank you for your kind attention.